Welcome to the Rad-On Smart Review Head and Neck Cancer series.
Today, we're really shifting gears. We're moving away from that acute phase of treatment, where everything is about hydration, pain, just getting the patient through.
Yeah, the battlefield phase.
Exactly. We're moving into the long-term reality of survivorship.
And the stakes here are, well, they're different, but you could argue they're even higher. If our last discussion was all about don't lose the patient during treatment, today it's about something tougher. It's don't ruin the next 30 years of their life. I mean, the functional deficits we see in head and neck cancer survivorship are they're almost unparalleled in any other site we treat.
That's so true. And we're getting better at curing these patients. With IMRT and concurrent high-dose cisplatin, the cure rates are great. But that success, it comes at a functional cost.
A very real cost. And it's now the primary concern because we're often treating younger patients, people who are highly functional before their diagnosis, and who expect to live for decades after we cure them.
So when we talk about late effects, this is the point we really have to hammer home. These aren't just temporary side effects. They become the patient's new baseline, their new normal.
Their permanent reality.
Yes. And that means functional outcomes have to be absolutely paramount, both in the planning room and in every single follow-up clinic visit.
Okay, so to give everyone a solid, high-yield way to think about this, I mean, the complexity of late toxicity can be overwhelming. What's the framework we should use to anchor ourselves? What are the big four things that always need a second look?
We can really simplify it down to four major interconnected pillars of function. And this is a great board-relevant framework. If your treatment plan affects swallow, jaw opening, saliva, or bone healing, you have to stop.
Stop and think twice.
Exactly. It needs double consideration, not just when you're planning the IMRT to spare dose, but also for years afterward in the clinic so you can be proactive. If you ignore even one of these, you're pretty much guaranteeing a quality of life catastrophe for that patient.
Let's ground this right away with a clinical case. This is the patient that every resident will see. The 60-year-old male survivor who walks into your clinic 3 years out. His cancer is gone, but his functional life is falling apart.
Okay, let's get the details.
He's 3 years post-definitive treatment. He was a T3N2C base of tongue cancer. He was likely P16 positive, given his profile, though this was before P16 status was really driving de-escalation talks.
So he got the full court press.
He got the works. Bilateral IMRT to 70 gray and 35 fractions with concurrent high-dose cisplatin, a really tough standard regimen for that stage. And 3 years out, his surveillance PT scan is clean. He's cancer-free. That's the win.
That's the win. But you can feel the but coming.
Okay. The but is that he is functionally miserable. He comes in with 4 classic late complaints that map perfectly to our 4 pillars. First, Trismus. He says, I can't open my mouth wide enough to bite into a burger. Eating in public is it's a performance.
The classic complaint, so socially isolating.
Then, aspiration. I cough every time I drink water, and sometimes I just wake up coughing.
Okay, big red flag there.
Huge. Third, severe xerostomia. My mouth is like cotton. I actually wake up choking at night because my throat is so dry, and I have to carry a water bottle everywhere I go.
The quality of life thief, right there.
And fourth, this is the high-stakes problem. He says, my dentist says I need a lower right molar extracted. It's got root decay, and it's right in the middle of the high-dose radiation field.
Wow. That is the complete high-risk checklist of late toxicity all in one patient. It just perfectly illustrates that getting the oncologic cure it's only half the job.
Right.
So now the question for us isn't about cancer anymore. It's how do we fix the damage? And maybe more importantly, could we have prevented this?
Exactly. So you're sitting in the oral board hot seat or just in a busy clinic. You need a structured, comprehensive plan. Let's hear the ideal 60-second board script, the way a resident should deliver it.
Okay, here's the CAN script. You have to deliver it with confidence and clarity. This is a cancer-free survivor presenting with established, classic late radiation-associated toxicities. These include dysphagia with definite aspiration risk, likely resulting from high dose to the pharyngeal constrictors and laryngeal structures, profound xerostomia from salivary gland injury, and trismus due to progressive fibrosis of the muscles of mastication. Critically, the need for a mandibular extraction in the high-dose field places him at extremely high risk for osteoradionecrosis, or ORN, management, must be objective and multidisciplinary. First, for aspiration, we require an urgent speech-language pathology evaluation and an objective assessment, specifically a modified barium swallow, or FEES, to define the physiological deficit and establish safe swallowing strategies. This must be paired with daily, structured swallow therapy and diet modification. Second, for trismus, we must measure the maximal interincisal opening and initiate jaw stretching therapy, often device-assisted, with referral to rehabilitation. Third, symptomatic xerostomia requires therapy using saliva substitutes, potentially sialagogues if residual function is confirmed, and reinforcement of strict lifelong dental prevention, including fluoride. Finally, the molar extraction request must trigger an urgent referral to an oral surgeon experienced with post-radiation extractions to prioritize tooth salvage via endodontics. If extraction is unavoidable, we require a mandated high-risk protocol, atraumatic technique, primary closure, antibiotics, and ORN risk mitigation planning.
That is just. It's perfect. It covers everything. What's so crucial there is how you immediately pivoted from just naming the problems to ordering objective tests and, importantly, activating the team.
Right. You're not just labeling.
No, you laid out an action plan. You're bringing in SLP, physical therapy, a specialist oral surgeon. It's not about just treating symptoms. It's about understanding the pathophysiology.
And that's our job as the radiation oncologist, right? We're the architects of this survivorship plan. We have to be the ones to identify the problems that our treatment contributed to, triage them, and then get the right specialists on board to manage the damage.
Let's start the deep dive on that first and I think most critical pillar, dysphagia and aspiration. Our patient coughs with water. But the real danger, as you always hear, is that aspiration is so often silent.
This is a point that you can't overstate it. Aspiration is frequently silent. A patient not coughing does not mean they are not aspirating.
And why is that lack of sensation so dangerous?
Because aspiration pneumonia, which can be subclinical for a long time before it becomes a major infection, is one of the top reasons these cured patients end up back in the hospital, severely debilitated, years after their cancer is gone. It's a true silent killer of their functional independence.
Okay, so let's break down the pathophysiology. Why does radiation cause this mechanical failure? Why is the sensory loss so profound?
The core mechanism is a relentless, progressive fibrosis. You get this collagen deposition and stiffness across the entire swallowing apparatus, which is an incredibly coordinated functional unit.
I mean, swallowing is this complex dance, right? It involves so many muscles and nerves.
At least 26 muscles and 6 cranial nerves. And radiation just disrupts multiple key targets all at once. It stiffens the muscles and it damages the delicate nerve endings that are responsible for sensation.
So for this specific patient, a base of tongue cancer, what are the key functional targets we're hitting?
We should think about 4 critical mechanical targets. First is the base of tongue itself. That's the engine. It provides the propulsion to push the food or liquid back. If that gets fibrotic, you lose the driving force.
So the bolus just sits there.
It just sits there. Second, the pharyngeal constrictors, superior, middle, and inferior. Their job is clearance. They provide that peristaltic squeeze to move things down. If they get stiff, you get residue left in the pharynx, which can then spill into the airway after the swallow.
Okay, so propulsion and clearance, what are the next two?
Protection and passage. So third, the supraglottic larynx. This is all about airway protection. It needs to elevate and close light and fast to seal off the airway. If radiation damages that movement, or worse, the sensation in the larynx, the patient might not even register that material as penetrating. That's where you get that dangerous silent aspiration.
And the final piece.
The cricopharyngeus muscle, or the upper esophageal sphincter. This muscle has to relax and open up to let the bolus pass into the esophagus. If it's stiff and in spasm, food just backed up.
So you get this cascade of failures. Poor propulsion, poor clearance, failed protection, and a blocked passage. And that leads to residue aspiration, chronic cough, weight loss, and eventually the patient just gives up on eating. They say it's too exhausting or too scary.
Absolutely. And think about that psychosocial burden. Mealtime becomes a source of stress and anxiety. It leads to social isolation. The patient stops going out to restaurants. They stop eating with their family. It's devastating. And that's why our prevention mindset in the planning room is so incredibly critical.
I couldn't agree more. You can't rehab a structure you never even tried to spare. So for residents contouring these plans, what are the fundamental rules?
It's 2 simple rules. Rule 1, you have to contour the swallowing structures whenever it's feasible. Rule 2, you must prioritize sparing function whenever it doesn't compromise the oncologic cure.
And we need some specific high-yield numbers to back that up for the boards. They want to know you understand the functional anatomy. So what are the critical dose constraints we're aiming for?
The two most critical mean dose targets are the pharyngeal constrictor muscles mean dose and the larynx mean dose. For the constrictors, while constraints can vary a bit, a common goal is to keep the PCM mean dose under 50 to 55 gray. You have to actively fight to avoid just blasting that whole structure with 70 gray if you don't have to.
And hitting that, especially with bilateral neck disease, can be a real challenge in the planning room.
It's a huge challenge. And for the larynx, the goal is really driven by voice and aspiration risk. The simple rule is the lower the better, especially if the patient already has some pre-treatment aspiration or vocal cord issues. If you can keep the larynx mean dose down in the low 40s or even the high 30s, you dramatically improve their chances of retaining function years later.
Okay, let's shift to the clinic. The prevention mindset has to be proactive, not reactive.
Absolutely. It starts with a baseline swallow assessment for any high-risk patient. That's anyone with bulky disease, a primary in the base of tongue or hypopharynx, or anyone getting bilateral neck radiation with chemo.
And the timing of the rehab is everything.
It is the single most important intervention. Swallow exercises must start before radiation begins and continue throughout the entire course. You're trying to preserve that range of motion. You're actively fighting the fibrosis before it locks everything down.
This brings up the difficult conversation about the PEG tube. For these high-risk patients, a PEG is often placed. What is the critical conversation you must have with them about it?
This is a major clinical pitfall. You have to be crystal clear. The PEG tube is there for supplementation only. It is not permission to stop swallowing.
It's a safety net, not a replacement.
Exactly. We know swallowing is a use it or lose it function. Even if they become dependent on the PEG during treatment, they have to keep trying to swallow safely every single day to exercise those muscles. If they stop, you are guaranteeing severe disuse atrophy and a permanent intractable dysphagia.
So let's turn back to our anchor case. He's 3 years out. His dysphagia is established. What's the management plan for him now?
First, we make it objective. We get away from the subjective complaint. Step 1 is an objective assessment. You order a modified barium swallow, an MBS, or a flexible endoscopic evaluation of swallowing, a FEE. Remember, cough with water is a symptom. We need the SLP to tell us why he's aspirating.
Okay, and just for the residents, can you quickly break down the difference? When might you choose one over the other?
Sure. The MBS is a video X-ray. It gives you this amazing comprehensive view of the entire swallow, from the mouth all the way down. It's fantastic for defining the biomechanics, how the structures are moving or not moving.
And the fee?
The FEE uses a flexible scope through the nose to look directly at the pharynx and larynx. You can't see the exact moment of the swallow, the camera whites out, but it's excellent for evaluating sensation and seeing where residue is left after the swallow. And you can often do it at the bedside, which is great for frail patients. We often use both to get the full picture.
Once that physiology is defined, what's the therapy?
It's an SLP-led rehab plan. It involves specific exercises to target the deficit, like the Mendelssohn maneuver for laryngeal elevation. It also includes compensatory strategies, things like posture changes, thickening liquids, pacing the meal.
We always have to check for mechanical blockage, right?
Always. If there's a mechanical stricture, most often at the cricopharyngeus, an endoscopic balloon dilation can be absolutely life-changing. It can restore a massive amount of function almost immediately.
And what about for those very rare, severe cases where aspiration is just intractable and life-threatening?
That is the last resort. We only consider things like aspiration control surgery after maximal medical and rehab efforts have failed. But the vast, vast majority of patients will benefit from aggressive, physiology-based rehab, not surgery.
Let's move to our second pillar, mesorestomia, the quality of life thief. Our patient is waking up choking.
That one complaint tells you everything about the severity. This isn't just a dry mouth. Xerostomia is this relentless discomfort, it's taste loss, it's difficulty speaking, it's major sleep disruption, and the most dangerous part, accelerated dental destruction. Having to carry a water bottle everywhere just to function, it completely changes your life.
So in the planning room, how do we prevent this? What's the high-yield board-level statement?
The primary high-yield statement is, spare at least one parotid gland whenever it is oncologically feasible. We're aiming for a mean parotid dose of less than 26 grays for the gland we're trying to save. Sparing even one parotid below that threshold gives the patient a real shot at retaining stimulated saliva, which is what you need for eating.
But that choking issue,
Yeah.
that's often driven by a different gland, isn't it?
Exactly. We can't forget the secondary targets. The submandibular glands are critical. They produce most of your resting saliva, that thicker baseline moisture that keeps your mouth lubricated when you're not eating. That's what prevents that awful nocturnal choking.
So you have to look at the dose to the submandibulars too, and the overall oral cavity.
You do. IMRT is a powerful tool, but it only works if you meticulously prioritize these organs at risk. If the submandibular glands aren't involved with tumor, you have to try and spare them.
Okay, so let's say we've planned well, but the patient, like our case, still has symptoms 3 years later. What's the management algorithm?
It's a three-tiered approach. We start with behavioral modifications, frequent sips of water, using a humidifier at night, sugar-free gum to stimulate any residual function, and we rely heavily on over-the-counter saliva substitutes and gels.
And then there's medication. When do we bring in the C. allegogues?
We use drugs like pilocarpine, but only if we can confirm there's residual gland function. I mean, if both parotids got 70 gray, those meds aren't going to do anything. But if you spared 1 to 25 grays, there's likely function you can stimulate.
And then the long-term sort of self-danger,
Yeah.
the dental piece.
You have to view xerostomia as a chronic, evolving dental emergency. Without saliva, the teeth they decay rapidly. We call it radiation caries. So we mandate lifelong, daily, high-potency fluoride and aggressive dental surveillance, with checks every 3 to 4 months at first. This is non-negotiable.
Okay, next pillar. Trismus. Our patient can't eat a burger. The clinical pearl here is that trismus is the late effect that's quiet at month 3 but absolutely devastating at year 3.
It's so dangerous because it's progressive and insidious. It starts as just minor stiffness, but due to that relentless fibrosis of the mastication muscles, the jaw can get severely restricted. We're talking an opening of 15 millimeters or less, and once it gets that tight, it almost never returns to a normal functional range.
So, mechanistically, what are the key structures driving this?
It's fibrosis of the primary muscles of mastication. The pterygoids, both medial and lateral, are the major drivers, but you also see it in the masseter, the temporalis muscle, and the TMJ capsule itself. These areas are often right in the high-dose volume for tumors in the base of tongue or nasopharynx.
So since it's progressive and largely irreversible, the whole approach has to be prevention first.
Prevention is the single best treatment, period. The strategy has to be proactive. Structured jaw stretching must start before radiation and continue throughout the entire course, and ideally for a long time after.
And this isn't just, trying to open your mouth wide a few times. What's the standard recommendation?
Patients should be using a dedicated stretching device, like a Therabite, on a daily structured regimen. We often prescribe 3 sessions a day, aiming for multiple sets of repetitions, holding the stretch. We have to get physical therapy involved early to ensure they're doing it right and to track their opening over time.
And in the planning room, what's the take-home message there?
You have to acknowledge the risk. If you have a tumor near the masticator space, you have to recognize that the pterygoid dose can be high. Even if you don't contour them formally, you need to visually check that your high-dose cloud isn't unnecessarily cooking those muscles.
So the ultimate board point is all about timing.
It is. If you wait until the 3-month follow-up to even mention trismus and jaw stretching, you are already way too late. You failed that patient.
Now we get to the 4th pillar, the one we all fear. Osteoradionecrosis, or ORN. Our patient needs a molar pulled in the high-dose mandible. That request is an immediate 5-alarm fire for a radiation oncologist.
It's absolutely devastating. ORN is exposed, necrotic bone that just persists for months after high-dose radiation without any tumor there. We're talking chronic pain, infection, fracture, fistulas. It often requires massive surgical salvage, maybe even free flaps. It completely derails survivorship.
Let's walk through the mechanism. Why does radiation make the bone so vulnerable?
The best way to remember this is the 3H concept. Radiated bone becomes, 1, hypocellular. You've killed off the repair cells, the osteoblasts and osteoclasts, so the bone can't remodel or fix microtrauma.
Okay, so no repair crew.
None. 2, it's hypovascular. The radiation damages the small blood vessels, so you have a severely compromised blood supply. You can't deliver nutrients, oxygen, or immune cells.
And that leads to the 3rd H.
Right. It becomes hypoxic. Low oxygen. And without oxygen, you can't fight infection or power cell metabolism. The mandible already has a tenuous blood supply, and radiation just pushes it over the edge.
So any little injury, like a tooth extraction, becomes a non-healing wound that just spirals into exposed dead bone.
Precisely. Which leads us directly to the number one trigger.
And what is that number one most critical trigger for ORN?
It's a post-radiation dental extraction in a high-dose mandible. You pull a tooth, you create a wound in bone that simply cannot heal. The soft tissue breaks down, the bone gets exposed, and the vicious cycle of ORN begins.
So the key is avoidance. What's the prevention checklist every resident needs to know?
First, pre-radiation dental clearance. Every non-restorable high-risk tooth has to come out before treatment starts so it can heal while the blood supply is still good. Second, lifelong prevention. Mandated high-potency fluoride and aggressive dental surveillance to prevent any late extractions by neglect.
And if a tooth does become a problem years later, what's the decision point? Extraction versus salvage?
You always prefer endodontic salvage. The first question is always, can we save this with a root canal? A root canal is exponentially safer because it treats the infection without creating surgical trauma to the bone. It avoids the trigger.
Okay, but for our patient, let's say the tooth is not salvageable. We can't just refuse if it's causing an abscess. What's the management algorithm?
You have to employ a structured triage algorithm. This is high-risk management.
Walk us through it. Step 1.
Step 1, triage and consultation. First, you check the dose history. Did that part of the mandible get 70 gray or more? You look for cofactors like smoking or poor hygiene. Then, you make an immediate, urgent referral to an oral surgeon who specializes in post-radiation management. This is not for a general dentist.
Okay. And step 2, if extraction is unavoidable.
Step 2, the planned extraction protocol. This has to be treated like a major surgical event. You need that experienced oral surgeon using an atraumatic technique. They have to get primary closure of the soft tissue over the socket, and you need a course of prophylactic and post-op antibiotics. And intense follow-up is mandatory.
And if the patient already has established ORN, what's the path then?
You start with conservative care, oral rinses, local debridement, antibiotics for infection, pain control, and mandatory smoking cessation. You only escalate to major surgery if it's progressing or causes a fracture.
Finally, let's talk about hyperbaric oxygen, HBO. What's the modern, board-mandated answer on its role?
The board answer has to emphasize avoidance and specialized surgical planning first. HBO is not a magic bullet. While it might be used in some protocols, maybe prophylactically before a high-risk extraction, it is not a universal panacea. You have to show you understand the primary prevention strategies first, and then mention HBO as a possible adjunctive measure.
Let's circle back to our 60-year-old patient and put it all together. Let's walk through the clinical decision-making step by step.
Okay, let's sequence the actions for this complex patient.
Problem 1, his aspiration symptoms. Coughing with water, choking at night.
Action. We prioritize the objective data. Order the MBS or AEEs immediately. Get SLP involved right away for targeted therapy and safe swallowing strategies. And we'd probably recommend a humidifier for the nighttime choking.
Problem 2, trismus. His mouth opening is getting smaller.
Action. Measure his maximal interincisal opening right now. Counsel him that this is progressive and we are already behind. Start him on a structured, device-assisted stretching regimen today and refer him to physical therapy to ensure he's compliant.
Problem 3, the xerostomia, discomfort and major dental risk.
Action. Education on hydration, saliva substitutes. We could consider a trial of pilocarpine. But most importantly, we hammer home the need for lifelong daily fluoride and strict, frequent dental surveillance.
And problem 4, the big one, the molar extraction request.
Action. This is the critical moment. You pivot immediately. You do not just agree to this. You contact the dentist, and you insist on prioritizing endodontic salvage with a root canal. If it is absolutely unsalvageable, then you mandate the full high-risk protocol: specialist oral surgeon, atraumatic technique, primary closure, antibiotics. You frame this as a life-altering surgical event.
Perfect. A great summary of how to manage the checklist. Now, what are the prevention levers? The things residents need to do from the start?
It's clear: prophylactic swallow therapy starting before radiation, jaw stretching also starting before radiation, prioritize salivary gland sparing in the plan, and rigorous pre-treatment dental clearance followed by lifelong prevention.
Okay, let's shift to the oral boards. There are specific reflexive answers that just scream, I don't get the nuance. What are the 3 big traps to avoid?
Trap number 1 is about aspiration.
Trap 1, the NPO forever reflex.
Right. If the examiner gives you an aspirating patient and your first response is, make him NPO, Without mentioning an SLP-led physiology-based plan, you failed. That reflex guarantees permanent disuse dysphagia. You have to treat aspiration with rehab, not starvation.
The second trap is all about ORN.
Trap 2. Casual post-RT extraction. If you get asked about pulling a tooth in the high-dose field and you just casually agree, you've ignored the single biggest ORN trigger. The answer must be to pivot immediately to salvage or high-risk planning.
And the final trap is about what you focus on during planning.
Trap 3. Forgetting function. If you're asked about IMRT planning and all you talk about is the parotid dose for xerostomia, you're missing the bigger picture. If you forget the pharyngeal constrictors, the larynx, the pterygoids, the examiner will think your awareness is limited to just dryness, not the essential functions of swallowing and chewing.
Let's do a rapid recall drill. Quick questions, quick answers to lock this in.
Let's do it.
What study defines aspiration physiology?
Modified barium swallow, or FEs.
Number one trigger for ORN.
Post-radiation dental extraction in the high-dose mandible.
Key prevention for trismus, and when does it start?
Daily structured jaw stretching, starting before and during radiation therapy.
Key prevention for progressive dysphagia.
Prophylactic swallow exercises and continued oral intake when it's safe.
What's the minimum survivorship checklist for late effects?
Swallow and aspiration screening, jaw opening measurement, xerostomia and dental status, thyroid monitoring, and assessing vascular risk.
Okay, now for our 6 clinical pearls. These are the high-yield takeaways, verbatim. Pearl number 1. Aspiration is often silent. Test it, don't guess it.
Context there is that you have to rely on objective data like an MBS or MS because a patient's report of coughing will miss dangerous silent aspiration.
Pearl number 2. Swallow therapy starts before radiation and continues during it.
Because prevention is proactive. You're fighting fibrosis before it sets in. Waiting until after treatment is often too late.
Pearl number 3. PEG is for nutrition support, not permission to stop swallowing.
It's a use it or lose it system. Patients have to keep swallowing safely to prevent disuse atrophy and permanent dependency.
Pearl number 4. Trismus is prevention first. Stretch early or regret later.
Because trismus is progressive and the only real defense is early, structured, device-assisted stretching from day one.
Pearl number 5. Root canal over extraction in a radiated mandible when feasible.
Because salvage avoids surgical trauma to that compromised bone, which dramatically reduces the risk of triggering ORN.
And pearl number 6. A post-radiation therapy mandibular extraction is a high-risk surgical event, not routine dentistry.
It requires a specialist, an atraumatic technique, and specific risk mitigation. You have to treat it with that level of gravity.
As a final thought, we focused on the damage, but the future of this field is really in de-escalation. Can we get the same cure rates with lower doses to these critical structures, especially in P16-positive patients?
That's the billion-dollar question. These late effects are dose-dependent. Reducing the dose, even by a few grays, could completely change the reality for thousands of survivors. That's what's driving the current clinical trials.
Time for our final board blitz. 3 multiple-choice questions to seal the deal. Question 1. Best next step for a survivor who coughs with thin liquids but denies pneumonia? A. Empiric antibiotics.
Right.
B. Make him NPO indefinitely. C. Modified barium swallow, or AES, with SLP evaluation. Or D. Start thickening liquids without an assessment.
The answer has to be C. You have to define the physiology objectively to guide the rehab. Guessing is not good enough.
Question 2. 2 years after 70 gray, a dentist plans a lower molar extraction. Best board level response. A. Proceed, just give antibiotics.
Yeah.
B. Delay extraction until 5 years post-RT. C. Prefer tooth salvage. If unavoidable, specialized oral surgeon plus atraumatic technique plus closure plus risk mitigation plan. Or D. Refer for immediate hyperbaric oxygen.
It's C all day. The answer has to prioritize avoidance first, then high-risk specialized management. HVO is an adjunct, not the first step.
Question 3. A patient develops progressive trismus 1 year after RT. Most correct statement. A. Trismus is usually fully reversible. B. Trismus is best prevented with early stretching started before or during RT. C. Trismus only affects the masseter muscle. Or D. Trismus is uncommon and not worth counseling.
The most correct answer is B. Trismus is progressive, common, and often only partially reversible. Proactive prevention is the only real answer.
Which brings us right back to the core mission. Curing the cancer is the first essential goal. But if we ignore function swallow, jaw, saliva, and bone, we really haven't finished the job.
That's right. Late effects are forever. They become the patient's permanent reality. So prevention, proactive planning, and multidisciplinary surveillance have to be central to how we practice head and neck radiation oncology.
Complete practice oral boards at radoncssmartlearn.com and subscribe to Radonc Smart Review for our next episode. Thanks for tuning in.